So, starting with this OR cycle, pre-op is the first time we encounter our patients. It's where we prep them for the surgical procedure that's going to happen that day. The main goal of this is to make sure that it is safe for us to do surgery on our patient. If you have like a very organizationally oriented kind of mindset, this is what we're doing when we prepare patients for an OR procedure or to have a surgical procedure done. The big thing we're doing, the big behavior, is assessment. We're gathering our baseline data because we know our patient is going to go through a change during that surgical procedure. Their assessment is going to be different after surgery than it was before surgery. So the ways we do this, first we need to identify our patients. By IDing our patients, how do we do that? Name, date of birth. We don't just confirm that on the wristband. Our patient needs to tell us their name and their date of birth. Then we've got to ID the procedure. So how do we want to do that? Same way. We want our patient to tell us what procedure are they having and where on their body are they having that procedure done. This doesn't have to be like, I'm having a total whatever, or a partial laparoscopic appendectomy, or whatever the procedure may be. They just need to be able to tell us layman's terms what's going on. Like, oh, I'm having my appendix taken out and it's on my belly. If they say, I'm having my gallbladder taken out, and they're pointing their head, we know that there is a problem here, and we're going to need to work with this patient to make sure it's safe to proceed. We don't know that consent is appropriate for that type of patient. Then we're going to do our review of systems. This includes everything that's happened to our patient in their past, meaning their medical history and their surgical history. When you think of review of systems, think back to health assessment. Remember every chapter when you asked, like your classmates, 700 questions about every body system that they have, like 10 ways of saying their ears are normal, 10 ways of saying their eyes are normal, all that kind of stuff. That's your review of systems. It's that very, very detailed, in-depth assessment on your patient. And then we want to get into the present, so our head-to-toe exam. This isn't an abbreviated head-to-toe exam like you may see some nurses do in a hospital. This is the head-to-toe exam you got checked off on. It is that full head-to-toe with your baseline data assessment. It's all the things. Then we're looking at our data assessment. So this is everything we get from the computer. We want to look at their labs and their other measurements to make sure that our patient is hemodynamically stable. This is a big thing. Hemodynamics, meaning hemo, blood, dynamic, movement. So is blood moving around their body in a way that we could call stable? Easiest way we measure hemodynamic stability is vital signs, specifically blood pressure and heart rate. If those are in equilibrium, we know that our patient is hemodynamically stable. When we look at their labs, there's a few things we want to look for that are also going to support our evidence that a patient is hemodynamically stable. Those are things like their hemoglobin and hematocrit levels. Are they appropriate, and is the ratio between them appropriate? There should be a 3-to-1 ratio between your hemoglobin and your hematocrit. Alterations in that are indicative of hyper or hypovolemia in our patients. Then we want to look at our white blood cell count. If it's elevated, that's a piece of data that lets us know there's an issue around hemodynamic stability. So we want to be very careful of those sorts of things. It doesn't mean there's an infection. Elevated white blood cell count just means there's an immune response being launched in the body. So we need to be suspicious that that patient could have an infection. Other thing we want to look at for our labs is our platelets. You never want to cut somebody open if you don't know that they can form a clot afterwards. So that's what we're really looking for. We're looking for our lab data, most of it around our CBC, and vital signs, especially everything that has to do with circulation. So blood pressure and our pulse rate. So as part of this assessment, let's look a little deeper at our medical and surgical history. For our medical history, we definitely want to know any allergies that our patient may have, advanced directives or resuscitation status. And part of the reason it's so important to ask about this in particular in the pre-op area is that this is the last time that we know our patient is going to be neurologically intact to let us know what their resuscitation wishes are. Every time or every point in time after the pre-op area, our patient is going to be sedated or heavily medicated with CNS depressants. And CNS depressants means they are not cognitively intact or have capacity to let us know very serious decision making. They are mentally impaired at every point in the OR after this. So it's really important to check in on that on every patient. What drugs they take, those of you guys who have taken a medical history on a patient, one of the things that happens every single time when you say, what's your medical history? Patients are like, oh, nothing, I'm healthy as can be. Well, what medications do you take? Oh, I take this for my blood pressure, this for my heart, this for my water pill, this for my diabetes, this for something else. Pro tip, ask them what drugs they're taking and you're gonna get all the medical history. So any drugs that could complicate this surgery are things we wanna be really careful of when patients are giving us that list. A lot of times we want to instruct our patients not to take their routine medications before they have a surgical procedure, especially like cardiac medications. Beta blockers are one of those ones that I'm always on the lookout at the bedside when patients are going to surgery. Reason being, when patients become hypovolemic, they start to present with a low heart rate, a low blood pressure, and an elevated heart rate. Right? That's one of our symptoms of hypovolemic shock. If patients are on beta blockers, those limit their heart rate response. So patients may start to drop their blood pressure, but their heart rate won't change. So it makes it much more difficult for us to assess hypovolemic shock in those patients. Then we want to look out for any supplements or any herbal remedies that patients are taking. Then previous diagnoses and family medical history. Last thing we want to touch on is social history, like smoking, alcohol use. If patients are smoking, we want to start counseling them preoperatively. It's like, look, you got to stop smoking at least for your recovery period. Because we know that lung healing starts within 24 hours of not smoking and gets better the longer patients don't smoke. So we do want that lung injury to be reduced around the OR process, even if they can only quit for a short period of time. That's still counseling we want to do in the pre-op area. Intoxicated patients, we always need to be assessing for intoxication. Couple big problems with intoxication around the OR. One, if somebody is drunk when they show up to surgery, are they really capable of giving consent to have somebody cut them open? Not so much. I would not feel great about cutting somebody open who's drunk. Anybody had a drunk friend that they've taken care of? Is that person really okay to give consent for surgery at that point? I don't think so. The other big problem physiologically is that there's a very high risk of a couple other things associated with alcohol use. One is hypovolemia because of the diuretic effect of alcohol. The other is prolonged bleeding time. So we always want to be careful around anything that's metabolized by the liver, like alcohol, and the need to make a blood clot, like after surgery. Then we're looking at our surgical history. So what past surgeries have they had? Where did they have them? What surgeries was it? And how did they tolerate that surgery? Specifically, how did they tolerate anesthesia? Because patients who don't tolerate anesthesia well, we want to know that going into the surgery, not discover it afterwards. There is a life-threatening complication of surgery that we're going to talk about in a little bit, but that's really what we're assessing for. And then this surgery, so identifying the surgery, is it appropriate to do it? So do they know what procedure they're having and where on their body that procedure is going to take place? And then we want to prepare them. Have they been NPO or nothing by mouth for an appropriate period of time? Most facilities have a policy that patients need to be NPO after midnight the night before their procedure. This is not evidence-based practice. The evidence base shows us that about 4 hours is all that patients need to be NPO leading up to surgery, but hospital policy is slow to adapt to what we're seeing as best practice. So you will still see in clinical practice that patients are NPO after midnight the night before, but really there's no difference whether they're NPO after midnight versus just 4 hours before their surgery. The big risk here is aspiration. They can vomit during surgery and aspirate their vomit contents. So that's what we're trying to avoid with that NPO status. And then signs and symptoms of active infection. During our data collection, we looked at their white blood cell count to let us know, is there any reason we should be suspicious of infection? Now we want to look at their body and look for any warm, red, swollen, oozing parts of their body where we can identify an active source of infection. So the real name of the game for assessment in our pre-op setting is our head-to-toe exam. We know that our patient is going to be physiologically different after surgery than they were before surgery because we're going to cut them open and we're going to alter their anatomy. So we need to get that detailed data collection. We need to know exactly what their capabilities were before surgery so we can assess for the difference after surgery. So a super important thing, we need to get that detailed, accurate, full head-to-toe exam for every patient that's going into the OR. Quick notes on our labs. So our CBC is all these components. It's our red blood cells, hemoglobin, hematocrit, all the different MC whatevers, different measures of red blood cells and maturity of red blood cells. Our WBCs, and then all the different types of WBCs, and finally our platelets. These are called fish bones. Sometimes physicians and surgeons choose to write down lab values using these type of things, these little pictures. And these are the numbers of those results that'll be recorded there. So for example, in this WBCs one, it'll say 8.6. And in their platelets, it'll say something like 300, but it won't say WBCs or PLT. It'll just say the number of the lab value in that space. We have the same thing for our metabolic panel. So this is what the fishbone will look like to record this kind of data. So one of the things I do want to differentiate for you guys and just expose you to is the difference between a basic and a complete metabolic panel. So the green areas is our basic metabolic panel, and all of these is our complete metabolic panel. And then if we do liver function, that's like an LFTs, which is our liver function tests. So that's an additional level of testing that we would do for patients with known liver disease prior to surgery. So before a patient goes to before a patient goes to surgery, these are kind of the checklist items that we need to make sure are done so that we know it is safe for our patient to go into that surgical procedure. Things like, has the informed consent been signed? Here's the deal with informed consent. Can you guys, as nurses, have a patient sign an informed consent? No, you cannot. Here's the deal with informed consent. The person doing the thing needs to be the person to give consent. Because in order to gain informed consent, there has to be an opportunity for a patient to ask questions about the procedure they're going to have. Since we're not the one doing surgery on a patient, it's really difficult for us as nurses to comment as to what the risks are, what the benefits are, what the possible complications of the surgery may be, what's going to be done if those complications arise. We can't reliably answer those questions because we don't do surgery. That's why the surgeon has to be the one to get informed consent on a patient. They're not going to be happy about doing this, but it's one of those responsibility things like, too bad you went to school for a long time to cut somebody open. This is part of what goes along with that. To have that privilege, you got to go through this pain of making sure people are okay with you doing that. So that's the deal around informed consent. We can, if patients just need the form signed, but they don't have any questions, the surgeon has talked to them about their procedure, we can have them sign the form. But the process of actually making sure that informed consent is obtained has to be done by the person doing the thing. Making sure our patient is prepped, making sure they voided before they go to surgery or their catheter's been inserted, all these other things, allergy bands, hospital gowns, ID bands, any other kind of stuff. This is kind of the checklist of things that we're looking for. So nursing diagnoses for pre-op patients. What do you guys think might be some good ones? Things that come to mind for me are a lot of risk for diagnoses. Risk for impaired skin integrity, meaning we're going to open them up. They're going to have impaired skin integrity because of the surgery they're going to have. Way I like to think about this, what's the only difference between trauma and surgery? Where it happens. Surgery is trauma. Trauma happens out in the world, like after a car crash when somebody goes through a window and cuts themselves. Surgery happens in a fancy room where somebody cuts you open. The end result is the same. You're going to get cut open. The only difference is whether you did that out in the world or in a very fancy cold room. So impaired skin integrity, absolutely. Risk for altered respiratory pattern. One of the things we know about patients who are going into surgery, they're going to get a lot of drugs. Fair? They're going to get a lot of CNS depressant drugs in order to sedate them fully for the procedure. And we know that CNS depressants cause respiratory depression as one of the main side effects. So risk for altered respiratory pattern, absolutely a thing because of that low respiratory pattern associated with CNS depression. Risk for falls, turns out when you knock somebody out, they fall down, right? Easy one. Any others that you guys can think of? One of the only actual nursing diagnoses that we really focus on preoperatively is knowledge deficit around recovery process or care post-surgery. But that knowledge deficit component is something we do because we do a lot of our teaching for patients preoperatively. So the plan, pro tip, always start with the end in mind. When we start to plan actions for patients, we need to figure out where do we want them to be come the end of this procedure. Physiologically, psychosocially, what do we want the best possible version of this to look like? So patients must be prepared to have surgery, and providers need to have all the information possible to know that it's safe to do that. So our head-to-toe exam, super, super important. We need to identify any potential risk factors our patients are exposed to well ahead of time or preoperatively before they have surgery and are unconscious and not able to tell us these things. Then we need to figure out where is this patient going after surgery. If it's inpatient, 2 thumbs way up, this is the best possible scenario because they are going to have 24-hour nursing care after surgery. So they're going to be well cared for. People are going to be keeping an eye on them, making sure that they recover properly. That is the best possible outcome. The thing we need to plan for and know about is where are they going to go after surgery? Are they going to a critical care or an intensive care environment? Or are they going to acute care, like a regular med-surg type floor? If they're going to ICU care, it's good to alert the family and the patient, like let them know that that's how it's going to go. Because it can be really shocking to wake up in a critical care or ICU room with all the monitors, all the people all around. It can be pretty frightening. So we do want to prepare them for that. Outpatient surgeries, here's the deal with outpatient surgeries. We need to know when is the patient going to be ready to go home, like what criteria, and how are they going to get home? No joke. I have had patients show up and who rode their motorcycle in to surgery. And they're like, oh yeah, I'm just going to get on my bike and ride home after surgery. False. You are not getting on your motorcycle after being CNS depressed and go tearing ass through town. Like, no, you're not doing that. That's ridiculous. Other patient, no joke. Arthur's taking me home. Excellent, you've got somebody there. Arthur's taking you home. Guy goes into surgery, comes out. Where's Arthur? Arthur's out in the car. He's waiting for me. Arthur was his dog. This dude's dog. He was saying his dog was going to take him home from surgery. Again, false. Your dog is not going to be driving you home from surgery. As awesome as Arthur is, no, nothing about this is appropriate. So anytime a patient is having outpatient surgery that we know about, eyeballs on the person who's going to be driving that vehicle home. And it must be a sober adult. Must, must, must. So, as part of the OR process, patients are going to be receiving a lot of drugs. So we need to do some screening to make sure they're going to be safe to get all the sedative medications and there's nothing that's going to compound or have an agonist effect over those medications. So medications that could potentially cause a problem for our patients. Here's a lot of the drugs that are commonly given during an OR cycle. So some of the big ones, antibiotics, we're going to start those prophylactically because thinking back to chain of infection, all the things that happen. So when the patients develop an infection, we are making a portal of entry, and then we are sticking our fingers in it or our tools in it in order to perform this procedure. Chain of infection, high risk. So antibiotics. Anticholinergics can be given because they do reduce secretions for patients, decreasing the risk of aspiration. So we want to look out for any other anticholinergic type medications that patients may be taking that can exacerbate that effect. So especially Parkinson's type patients, we want to be really cognizant of when they last took their medications, those sorts of things, and report those to the OR team. All kinds of other things. We talked about beta blockers already. Another big one is if patients are on chronic long-term pain medications, we are going to be giving more opiates and more CNS depressants in the OR as part of the sedation protocols. So we want to be really careful that patients aren't taking additional morphine, or we know what additional morphine they've been taking, so we don't overdo the CNS depression and cause respiratory failure in these patients while they're in the OR. So big, big deal. Next, for the implementation phase, we want to really make sure our patient, we want to do all the things that we can make sure our patient is safe to go into that unconscious surgical environment. So day of surgery preparation, no cosmetics, no nail polish. Why not? Well, first, no cosmetics. I don't know if any of y'all been to the mall anytime recently, but there are people running around there that do their makeup in such a way that they look like they have a medical disease. So we do not want any of that going on where if you look at them like, oh man, you look jacked up. We don't want that to be part of our assessment. So the big theme here is we can't have a patient who has anything on their skin or their body that's going to impair our ability to visually assess whether they're hemodynamically stable or not. Because think about this, things like foundational makeup or blush. If patients put that on, do we know their skin tone? Do we know their skin pallor? No. Those cosmetics are masking their natural skin tone. So we lose our ability to assess for things like hypoxia and cyanosis in our patients. Nail polish, it's a problem for the equipment to measure hypoxia, so our pulse oximeters don't work as well. We can't check cap refill as effectively. So we can't have anything on a patient that's going to alter our ability to assess them. Includes things like dentures, prosthesis, any of that kind of stuff. No joke, I opened up an OR for a team and we transferred the patient over to the bed and the patient's leg fell off. We didn't know that he had a prosthetic leg until we're all like, oh my God, there's a leg on the floor. The dude wasn't in there for a leg surgery. So it was very shocking to us to see someone's leg just fall off their body. Do the OR team a favor, take off their prosthetic extremities or any other prostheses before they go into the OR, because it can be really distressing when body parts fall off of people. Voiding before surgery. Got to be careful of that because it is a thing. The general kind of guidelines around when a patient needs to be catheterized for surgery versus not is if the total recovery time is going to be less than 4 hours, then we can usually have a patient void in pre-op, so we know their bladder is empty, and then they don't need to be catheterized for the procedure. If the total recovery time is going to be greater than 4 hours, then we're probably going to be putting a catheter in that patient just to keep the OR environment as sterile as possible. If patients are having a hard time with getting cath, they're really resistant, that's okay. These can be done in the OR after they're already sedated, and that's just kind of a part of the surgical prep. So if they're really concerned or having a lot of anxiety about it, that's okay. We can handle that when they're already unconscious. Teaching. This starts to occur way ahead of time. This is one of the main things we do in the pre-op area, whether it's pre-op in a doctor's office for our outpatient surgeries or pre-op in a hospital setting. We always want to make sure we teach our patients, get that teach back that they've intaken our information, and we want to provide written material as often as possible to reinforce the teaching that we're providing these patients. We want them to know what to expect and how to participate, particularly in their recovery. So the the patient concerns that they may have. A lot of patients are fearful of what it's going to be like when they wake up after surgery. So we want to really orient them to what is it going to be like. You're going to be in a recovery area. There's going to be a lot of other nurses around asking you a lot of questions about how you're feeling, how your pain is, things like that. Other patients have a lot of concern around the pain that they'll be in post-operatively. So we want to let them know that we have lots of medications available to help manage their pain, especially in that post-operative phase, immediate post-operative phase. And then at the hospital, we want to make sure they know where should their family wait. And we want to let patients know where their family is going to be waiting also. Patients can have a little bit of distress thinking we're just going to like boot out their family as soon as they have surgery. So we do want to reassure them that's not the case. Where will they be able to see their patient and when? So show them where the recovery room is and approximately how long the surgery is going to be. A lot of facilities now have those visual tracking boards. So they're given a code and can actually track when a patient goes from pre-op to the OR to PACU to the floor, wherever they're going to be recovering. So families can track them. And then for ambulatory surgery, again, they must have a safe ride home that is an adult human who is sober. Must. No joke. Because they pull some sneaky stuff on you. You got to watch out for that stuff. So then nursing management for the day of surgery preparation, we talked about all these things. The other big deal is their allergy bands and all the wristbands that need to be in place. So the red one is our allergy band. Those come in a couple different flavors. One is the red one that just says allergy on it, and we'll put that on a patient if they had a medication allergy. So if they have no known allergies, they won't have a band on at all. The other flavor of this is we'll actually write, like everybody will get an allergy band, and we'll write on it what their allergies are. So it might say something like penicillin or NKDA, no known drug allergies. So they'll get an allergy band that says they have no allergies, just so that information is readily accessible to the patient anytime they need it. The yellow one, it's our fall risk band. Everybody in the OR is a fall risk because we are going to make them like unconscious, and then after surgery, they're going to be like your drunk friend. So they are all a fall risk. Then there's our ID bands, which name, date of birth, all that kind of good stuff. Then there's this one. They're either blue or green that facilities have. These are our blood bands. So any patient that's been type and cross-matched or screened to receive blood products, we need to make sure that these bands are all intact. Each one of these segments is a sticker that if our patient needed blood in the OR, we'd peel off that sticker, send it to the blood bank, and then they would send us the appropriate products for that patient. One super important thing with wristbands is they cannot be on an extremity that is having surgery. Sounds obvious, but if a patient's having left shoulder surgery, their wristbands can't be on their left arm. The reason is once that surgery starts, we're not going to be able to access those wristbands in order to verify any of that information. So the wristbands always have to be on a non-operative extremity. So then for evaluation, making sure that everything's been done right, how do we know if we've prepared our patient for their surgical procedure? Well, can they tell us what procedure they're having? Do we know that they're able to give consent? Are they hemodynamically stable? All those sorts of things. And then how do we know if our patient is ready for surgery? Can they tell us their procedure? Can they tell us what's going to happen after their procedure, where they're going to be going, those sorts of things. We want to make sure the teaching is all done ahead of time. This is an example of a pre-op checklist. And these exist both inpatient and outpatient settings. In the inpatient setting, they're usually like embedded in the medical record, in the computer documentation. In the outpatient setting, they can still be paper, kind of like this one. And the way it works is for every category, the nurse will initial that that's been done by them. For computer documentation, you're inputting that data and then submitting all that, which is your electronic signature that you've done those things. But it's things like vital signs. Has their assessment been documented? Do they have any blood work that's been done? So their hemoglobin, hematocrit, all their CBC results. And then, have they been MPO? Do they have an ID band on? And then what's going on with other valuables and any prostheses that the patient may come in with. That's it for pre-op nursing. Next, we're going to get into what happens in the OR.